I've been photographed, I do. I should have been a model.
What's this going on? Playboy of the month?
So, Kelly, hi. So you're one of our AMPs.
I am.
And I just want to share what we do with the AMPs here in the triage and treat area. So just tell us a little bit about the box, which is essentially like a virtual fracture clinic.
Okay, so the work of the AMPs was audited a number of years ago to see if our decision making was correlated with the consultant workforce. So the consultant body would go through the virtual clinic, which is all patients referred in to us, and we now undertake that decision making, holding back anything that isn't that we feel is outside.
So these are
remit.
ED referrals.
They're predominantly ED referrals, yeah.
And then you're triaging them to either recall, fracture clinic, admission for surgery, etc.
Absolutely, yeah. Or an appointment. We're ensuring that they can follow the pathway through, and if unfortunately there's not enough information there, then we recall that patient back for further assessment.
How many of you are there?
There are about 8, but in terms of whole-time equivalents, it's I think it's about 7.
Okay, and the service you provide is 8 till
7 o'clock in the morning we start, and 8 till 8:30 at night.
Okay, and it's Monday to
Friday.
Monday to Friday.
And Saturday and Sunday is a weekend, just literally to do the orthopaedic virtual clinic.
So how do you support the on-call registrar?
So in terms of supporting the on-call registrar, we've got we undertake the urgent assessment of patients that are referred into the department or need to be recalled for further assessment, and that was traditionally all done by the registrar on call. We take the emergency department referrals as well, in that we can slot them into any spaces that are in that urgent calendar. And we also have an individual member of staff, as our staffing is allowed, we put an extra member of staff on to support the on-call team for the day.
And you've been trained to do certain procedures like?
So the procedures that we're currently just building our skills upon are things like taking the cord recliners, nail bed repairs, additional manipulations, but currently we can assess any patient except for a laceration, acute laceration. That's not something we've done yet, we're just in the process. But we manipulate wrists, fingers, toes, can mould casts, so it's those type of procedures that we do at the moment, as well as a full assessment and diagnosis and treatment.
And then apart from ED referrals, you're also handling GP referrals, so that prevents ED from getting clogged up with these extra patients?
Yeah, I mean the emergency department, the GPs have a system by which they can refer through our .net account, so patients, the doctors know that they can refer in their non-urgent cases that
and there's also a phone number
within 24 to 48 hours. The phone number goes through to the on-call team, and whoever has got that phone at that time will take those calls, and we'll either divert them back to PRISM, which is our .net referral system, or we bring the patient down and slot them onto the nurse practitioner calendar, or occasionally it might need the registrar full stop.
And you've been able to share this kind of model with other people around the country?
We've had questions asked of us and how we managed to do that, and we've shared that. I mean, our role is a master's level. All of our juniors come in at normally around a band 6 or possibly a band 7 with some experience, and they need to undertake the masters in clinical practice, and that's a minimum of 3 years, includes the nurse prescribing.
Kelly, thank you very much for your time. That was lovely. Thank you.